So Valenchia is the lead for the state of Kentucky for our Project Firstline activities. So she has been instrumental in working directly with the Project Firstline program office and the full cadre of program officers that are in this area at CDC and really helping to push forward these basic infection prevention and control training activities. So she is not only a very skilled advanced practice registered nurse, but also a very skilled in focusing on these basic activities and putting it within a new type of training context. So we're happy to have her talk a bit about this, and she introduced this at boot camp last week, talking about how we can approach infection prevention and control competence as we work our way through the big waves of the COVID-19 pandemic, and then try to begin to use simulation as a tool. So can I turn this over to you, Valenchia, and I will hopefully keep up with you with the slides.
Yes, thank you, Dr. Carrico. Today we will be discussing the infection prevention and control competence in the post-COVID-19 era by using simulation as a tool. A couple objectives here is we're going to be looking at the current state of healthcare associated infections in the United States. Basically, what has happened since COVID arrived on the scene? What have we seen with the healthcare associated infection levels? We will also be describing current approaches for education and training, what we are currently doing to address training and education of basic infection prevention and control practices across the spectrum. And then we will look at new approaches that the Kentucky Infection Prevention Training Center is implementing in the form of simulation training to help narrow this gap that we have seen that COVID has so clearly exposed in our education and training when it comes to infection prevention and control practices. Next slide, please, Dr. Carrico. All right, so what we see from the NHSN, which is the surveillance system that healthcare facilities report infections to, is that there was a significant rise in healthcare-associated infections such as CLABSI, CAUTI, ventilator-associated events, MRSA, during the second half of 2020. Now we know that COVID basically hit the scene around the beginning of 2020, and that's when we started seeing things going downward or spiraling downward. COVID directly challenged our knowledge base. It challenged how we prepared our healthcare and allied health staff to respond in emergency situations, and that's why we see an interesting increase in significant levels in healthcare-associated infections. Prior to that, though, we did do very well. There's been a decline since 2015, around till 2019, in healthcare-associated infections in U.S. hospitals. But more interestingly, we saw that there were no increases in surgical site infections or C. difficile infections during this period. And this is across all healthcare settings, including long-term care. Now, the question becomes, why is this? Well, the answer to that is because in the operating room, the OR, there are very strict and solid procedures and practices to infection prevention and control. And so if one of those things are not in place, sometimes surgeries don't even take place. We can also think that during COVID, elective surgeries did not happen as much. And so maybe that contributed to that no increase. We also know that when we look at C. diff, no increases there, is that actually COVID improved adherence and consistency in our approaches when it comes to C. diff. Now, during this presentation, we'll take a closer look at what were some of the issues that occurred and why did this cause in a significant rise of infections overall. Next slide. So let's take a look at what happened during the pandemic. We saw that a lot of nursing staff were shifted from their comfort zones or areas where they felt comfortable. We saw OB nurses move to med-surg, taking care of med-surg patients now. We saw people in different roles that they normally did not work in or perform in. People had to take on healthcare workers had to take on new care activities, which challenged that knowledge base. And if there's no foundational knowledge, that we clearly see that the effects of that is increase in infections. There were also variations in supplies available for care. We know that everything was on back order, including some flushes and a shortage on supplies, and people started improvising and doing different things and deviating from standard practice. And one thing that comes to mind is the community saline bags when these flushes were on back order or shortage. Community saline bags were then used, nurses or healthcare workers created their own flushes. And that in itself posed tremendous risk of contaminating the bag and transferring pathogens that way. And then just overall systemic failures. We see that there was inability to apply that basic knowledge, poor use of standard precautions. For example, if we are caring for patients that cough, we have to make sure that we always wear respiratory protection, and that did not happen. That also contributed to the contamination of this COVID-19 between healthcare workers and patients, because those basic standard precautions did not take place. Was it a lack of knowledge, lack of standardization, accuracy? We don't know. We do know that the healthcare settings did not promote or help promote making sure that standard precautions are performed every time. And maybe healthcare personnel did not even know when to accurately perform standard precautions during the pandemic. We know that, for example, if we do not use personal protective equipment correctly, that it affects how much we keep in our storage supplies and even what type of PPE we have on hand. And so all of that underscores the importance of pandemic preparedness, and to make sure that we're prepared for the next pandemic or the next disaster, we need to address these issues now. Next slide, please. So this diagram shows knowledge and practice in the continuum of infection prevention. At the bottom, we'll take a look and we see academic preparation. So this is how, when we go to school, in schools of nursing, allied health, public health, we are prepared academically. The knowledge is given to us. We then perform some tests to show that we have we understand knowledge and we learn this knowledge. This is that basic theory, knowledge, and practice. Now, this setting here is very controlled. It's a classroom setting, or you have a preceptor that watches what you do and you perform. The second level is the competence development. In this level, this is when after school you go into the real world. Now here, there's a lot of variables that's not controlled. Here's where we actually have to practice. And this is where practice and process evaluation takes place. For example, we look at things like how often central line dressings are done, how well we perform these, and we apply then that knowledge into the real world that we gained during academic preparation. Now, this is where a lot of our challenges lay, right here, taking what we learned in the academic preparation and applying it into the real world setting, because that is what COVID exposed, those gaps that our healthcare and frontline healthcare workers do not know how to transfer that knowledge appropriately. And that's issues, they ran into issues when they were moved from areas where they here or they were put in different roles. This is because that foundation was not strong enough. If we look at the very top there, the healthcare-associated infection identification, this is where we move novice to expert. So it comes over where we look at what are the effects of our work on our patients. And this is where we look at an increase or decrease in infection rates during, but all this shows us that the foundational knowledge has to be strong and solid for everything else to then build upon that. And so this is what we are focusing on, and what with Project Firstline in the Kentucky Infection Prevention Training Center is strengthening those foundation knowledge and closing those gaps. I always use the example of if you are building a house, you built a brand new house, and you walk in for the very first time, and you see a big crack running across the living room and dining room. Are you just going to take a look at it and then say, I'm gonna put a rug over it to cover it up? No, you build the thing that's going on. You have questions like, why is this happening? And then you want to go under and see what the issue is with the foundation. Why is this crack visible? And so the crack that has been exposed by COVID, and we're going back to basics by fixing it with basic infection prevention knowledge and training. Next slide. So performance and outcomes challenges. The challenges that we see in healthcare and frontline healthcare workers run into is application. Like I said previously, taking the knowledge that was gained during academic preparation and applying it into every setting the same way. So whether you are drawing up vaccinations in a drive-through vaccination clinic, in a small library, or in a high-tech pharmacy, the high quality and standards of infection prevention and control need to be present at both of those areas. It shouldn't deviate because the setting changed. And then also this speaks into the transferring the knowledge. How do we transfer what we have learned in one thing in class or in school into another area of practice? Knowing and understanding the why and the how is very important, because if we enable our healthcare and frontline healthcare workers to understand the why and the how, they can then make sound decisions in the absence of direction. So when there is no supervisor or there is no IP looking over them or instructor, they can still make the proper and safe choices during their care activities with their patients. And then if we understand the why, we're able to recognize breaches in our practice. This can then lead very important discussions, because if staff don't feel supported to perform their roles properly and safely, this could be one staff member speaking up and saying, I feel that we don't have hand sanitizer, we do not have soap every time in all the bathrooms. Those are important things, because we know hand washing is the single most important thing that we can do to prevent the spread of transmission of pathogens. So we need to enable and foster a workplace where people can talk about if they made a mistake, if they see something wrong with the process or the system, so that those things can be fixed, because some other person may be having the same issue and not feel free to speak up. So creating that environment where we can have these discussions, recognize breaches. It could just be a lack of understanding or misunderstanding, so that we can correct these practices in the end. This then makes sure that we have sustainable practice, and that even though we experience staff shortages or changes in staff, that this does not affect the way we perform care safely and prevent infections. Next slide. So the basis for infection prevention and control practice competence. So the literature here is what the CDC then used from Dr. Carrico and others to help influence or the core elements of infection prevention and control practices. And we'll be looking at that on the next slide. The CDC used these documents and others to compile a list of competency in infection prevention and control training for public health workers and hospital personnel. Next slide. So here are some core infection prevention control practices that the CDC developed using the literature you just saw in the previous slide. I highlighted safe injection practices because we will be looking at that later on in this presentation. Next slide. So what was the CDC's response to when they noticed all of these gaps and all of these flaws in our education and training of our allied and healthcare workers, our frontline workers? The answer is Project Firstline. Project Firstline is provided a starting place so that we can correct practices, and it's important to understand that we are not just training and educating healthcare workers, but we also have to retrain healthcare workers, because training sometimes happened by urban legend, or they have a lot of outdated information that we see surface. So making sure that we dispel some of those myths and stuff about proper care and preventing infections the right way. Promote an ability to apply the correct knowledge and the correct practice every time in every setting. It's one of the goals of Project Firstline. And then the information is standardized information across all topics, and content experts at the CDC then created this. The Project Firstline also has a bunch of blogs or video blogs that you can watch. They're 10-minute, 30-minute, 60-minute PowerPoint presentations and infographics, posters, lots of material that you can utilize in your setting. The difference in these 10, 20, 10, 30, and 60-minute presentations is that the idea or the thought behind this is that this training can take place during morning huddles, short meetings, and it's sometimes referred to as bite-size or snack content, so that we know that healthcare workers are extremely busy in time. They just have a few minutes of lunchtime, but then they can still learn new information. Partnerships, the CDC reached out and they have multiple partners to make sure that this information is dispersed all over to all frontline healthcare workers. And there's a big emphasis on understanding the why. The why is very important. The why can never be something like, well, that's how we've done it for the past 20 years. That is not the appropriate answer for that. If that's the answer you receive when you ask why, you may want to look a closer look at these practices. The answer has to be grounded in evidence-based practice. Next slide. Here are some of Project Firstline's partners. The American Medical Association Stories of Care is where individuals tell their own stories. We have the Asian and Pacific Islander American Health Forum. This is where they translate this infection prevention and control knowledge in various different languages, eliminating language as a barrier to understanding and gaining knowledge on infection prevention and control. And then there's us, the Kentucky Infection Prevention Training Center, and our focus is simulation. It's incorporating simulation into infection prevention training. This is a very new approach that hasn't been done before, but we have seen a lot of successes in simulation used in other areas, and that is why we have taken on this challenge. Next slide. So simulation and infection prevention and training that we're using here in the Kentucky Infection Prevention Training Center. So there's a basic assumption that microorganisms are not visible. So we cannot see microorganisms. The transfer of organisms is invisible as well. And now the challenge becomes preventing the invisible. This is very interesting. It's kind of like it's like a ghost, right? We know it affects, and we know microorganisms cause death and lots of illness and lots of complications, but we don't see these, our enemies. And so our challenge is trying to fight this invisible monster, as I call it. And so now with simulation, we are going to really make the invisible visible and use that as a teaching method. Because we know adult learners, they perform better when they can be engaged in education and training activities, when there are visuals available, because it can stick in their head, and when it makes sense to their practice areas. We want to give them exactly what they need and tell them what they need to perform their duty in their jobs safely. Next slide, please. So the literature here is some information on simulation. Pam Jeffries, she developed the framework for implementing simulation in nursing education, and we've seen a lot of success there. Dr. Carrico, our very own Dr. Carrico, she then used simulation to teach nurses. And in this study that you see right there, she looked at, this study looked at healthcare nurses in the emergency department, and they were split into two groups. One group received, both of them received the standardized training, infection prevention training that the hospital has available. But one group then had this visual component in the form of simulation of a, like a dummy that coughed, and they were able to see these invisible droplets in the air. And then the study was to look at if behavior changed in these nurses after they've seen that, and it did. It significantly changed. Nurses used eye protection and masks to protect themselves when they were taking care of patients. So we have evidence that these visual aids and these visual training materials in the form of simulation does work and is very impactful. Next slide. So Kentucky Infection Prevention Training Center, our approach is that we use the information created by the experts at the CDC with Project Firstline, because this content is basic and also has a lot of accuracy and consistency. We then develop skill packets, training materials, these simulations, and they get reviewed by the CDC, Project Firstline program officers, infection preventionists, and staffs. And then we then are able to provide all of this training material, videos, photos, graphics in our training center, and also house them on Haymarket, Medical Education, MyCME, for enduring access and continuing education credits, and also certificates of completion for non-licensed healthcare providers. Next slide. So far, the 5 simulations that you see on the screen have been created already. They've been reviewed and content was approved by Project Firstline. Recordings and demonstrations are under review, and we anticipate moving these to MyCME site for housing by November 2022. Next slide. So now we're going to take a quick look at one of our simulation packets. This is actually one that I presented at the Infection Prevention Bootcamp last week that we had on safe injection practice skills. We use information or the structure by the Society of Simulation in Healthcare, looking at debrief, the simulation, pre-brief, excuse me, the simulation activity, and then a debrief. Next slide. So as you see there in the first slide, the pre-brief, we really look at the background of the information on the subject matter, just not looking at what are safe injection practices, why they're important. Next slide. We then continue at what are some examples of unsafe injection practices, because people may have done some of these and not even know that they are unsafe practices. Next slide. This is a screenshot of the simulation, actual simulation video. In that video, the nurse prepares vaccination or draw vaccination and makes a bunch of errors contaminating the syringe. And so the audience then are able to identify errors, and that leads up to the discussion. Next slide. In this discussion, we see different errors that the nurse made, and then we have these pictures that show the proper way of doing things, cleaning the surface, hand hygiene, disinfecting the vial stopper every time, aseptic technique when combining needles to syringes, and how to properly do all of these things to avoid contamination. Next slide. And then we bring that visual component. We make these pathogens or germs come alive and visible through the use of fluorescent powder. And under that blue light, you can see the orange area is when the nurse made all of these errors, including not performing hand hygiene, dropping a needle in a syringe. That's all picked up pathogens, and it was introduced into the vial. So you can see there that stopper is also illuminated, meaning that is the reason we always want to clean and disinfect the stopper every time we go in. And then I always ask the audience, who would like a dose of this vaccine or this medication? And usually the answer is nobody. Next slide. The second simulation we used, this was an actual video of a nurse performing a bunch of things correctly, but made one key mistake. As you see there, she's using a needle in a syringe and injecting the medication into hepatitis C infected patient. A backflow of blood occurs with injections, and now the hepatitis C viral particles has entered the syringe. And then she discards the needle, or he or she discards the needle and then puts on a brand new needle and goes back into the vial. And what happens? These viral hepatitis C particles are introduced into the vial, and then every subsequent patient receiving a dose from that vial is infected. We use real world examples because this actually happened in 2008 in an endoscopy clinic in Nevada, where nurses were told by their manager to reuse syringes to save money and only switch out needles. And then the discussion then becomes, should the nurses have known better? What should they have done? Next slide. And then at the end of that skill station or simulation, we then once again show the impact there of what would have happened if we could see contamination or pathogens or germs in vials and syringes. As you can see in that picture, the needle, which is a brand new needle, is not illuminated, but the vial, the syringe is illuminated. Now, some people are probably in an area where they do not draw up vaccines, but the same concept applies to the insulin injector pens that we use in our settings. Nurses, this insulin injector pen is only for one patient, and then the needle needs to be switched out, and that's appropriate in that case. However, if I don't have patient A's insulin injector pen and patient B uses the exact same one, is it okay for me to just switch out the needle and then use it on a different patient? And the answer is no, because now we know that the backflow of blood occurs, and then it is in that needle. So whatever patient A has, B will have, and vice versa. So you never want to use those insulin injector pens on different patients. And then in that, the next slide, this is the evaluation tool that we use for both learners and it is in our skill packets, so that you make sure you're hitting things while teaching and performing this this training session. The skill packet also has a step-by-step menu that tells you exactly what you need to set these up in your own setting. The videos that you saw or that we produce have no sound. So you can use it then in your setting, customize it to your audience to make it more impactful. Next slide. The simulation under development are blood culture collection, standard precautions, respiratory protection, catheter-associated urinary tract infections, and ventilator-associated events. And then also, we really want to hear your ideas. We want to hear what are some of the things you struggle with in your setting, and what we can do to help. We can possibly create some of these simulations, scenarios, and set these up if this is a issue that you're experiencing and not sure how to train staff while you're seeing repeated mistakes and errors being made. Next slide, please. So to contact us, we have our website is www.kyiptraining.org, and that's a screenshot. If you get to this page, you are at the right place. Please send us emails, subscribe. If you want some of these videos that you've seen during IP Bootcamp or some of the examples here, please subscribe to our newsletter. We will send out communication when these are ready for use. And with that, we have come to the end. How am I doing on time? Okay.
You're doing great. Great on time. So,
okay.
Good. So then we have the chance then for any questions that people may have. I know, Valenchia, you talked about the processes that are involved in developing simulation and the approach and using that, the standardized method of pre-brief with the content and then having that simulated event and then having the chance to debrief. And you mentioned about the use of that for training, but then also how to use that to help a facilitator. And so what have you learned about using this in from those two different perspectives?
So every time, it depends who your audience is, right? So if you are in a position to make changes in healthcare, I was the example of safe injection practices. I spoke to IPs and managers, educators. If we see that our healthcare personnel struggle with putting the needle to syringes and performing asepsis, how do we empower them to do their job properly and safely? Maybe introducing needles and syringes that do not need to be connected safely, while continuing to focus on the training and education there. If I speak to students, we really want to get the basic infection prevention control practices solidified in their training as they go out and become healthcare workers on their own. So facilitating those types of discussions, seeing or hearing, if I have to wash my hands, but there's stations too far, there's no soap, things like that. How do we empower healthcare workers to do what we ask them to do, what we're training them to do in the settings that they have to perform this in?
Any other questions from the audience? You can put them in the chat and we can address those. It would be great. I know that there are people that were at attended boot camp, and if you have comments on how to improve these, how to make them easier for people to use them, we certainly are interested in that as well. So, Dr. Ramirez, do you have any questions?
I think that this is a great way of. We have to be creative or have to generate new educational programs. Now, really the question that I have is something that Valenchia started the presentation. That I probably asked this to Valenchia and you, Ruth. I don't understand the idea that during COVID-19 we have increased on nosocomial infections. Or the number one being the ventilator-associated events. But then Valenchia following the CDC story, she said, well, we have decreased on CD. And the CDC said, well, we have decreased in CD because we wash hands because of COVID-19, and we use PPE because of COVID-19, and we do environmental cleaning because of COVID-19. But in my mind, sometimes it's difficult for me to say, okay, we decrease CD, but we increase ventilator-associated events or bloodstream infections, because the things that are for decreased CD are the same things that we were washing hands or we were not washing hands. We were using proper PPE or we were not using proper PPE. What happened during why some nosocomial infections decrease and other increase?
Yeah, I think your question, I think, is a great one, because the emphasis was on, again, on primarily on isolation. And again, the cases for CDI, these were cases of internal transmission. So it wouldn't necessarily be a new case that may have been identified as an outpatient. These would be reported through NHSN. So this would have been an individual that developed this as part of their care practice. So the hypothesis is that because isolation was used more frequently, that patients were segregated more frequently, and that facilities were more intentional of promoting hand hygiene, and that facilities were more intentional of ensuring that healthcare workers had personal protective equipment. So again, all of this is hypothesis. Now, there isn't anything about, well, was there, quote, better antibiotic use? Were we better about preventing the actual, GI disruption and the emergence of that organism? It's mostly looking at transmission opportunities. And I think that's what has been a little bit puzzling. That is it, why were we seeing increases in some of these other areas, but we didn't see increases in CDI or surgical site infection? The supposition was with SSIs, because nobody monitors practice better than surgical teams, that they are very specific. Everything is very regimented. And the thought is that was the use of isolation and PPE more consistently used across the entire patient population. Therefore, there was almost a secondary benefit in patients with C. difficile, because there was a lot of focus on environmental infection control. And we know that has been a big issue with room cleaning, and perhaps this spore that lives in the environment longer periods of time. There was less opportunity to contaminate a patient environment because everybody was going overboard with environmental infection control. So were these contributors to preventing those transmission opportunities? Nobody knows. So there isn't really anything definitive in the literature, but there is just that supposition that C. difficile C. difficile benefited from the isolation practices that were so widely used in environmental infection control.
And if we can apply those same strict practices that they have in the operating rooms to every setting, we can hopefully see the same result, which means no increase in, hopefully a decrease in infections.
But like with bloodstream infection, there was nothing different with COVID that you would do with like your ejection technique. So, still accessing, and nothing different with COVID that you would do for dressing changes. There was nothing different that you would do for blood cultures, nothing different that, you would do, for urinary tract, those that had indwelling urinary catheters. So the supposition is that the activities that you would do more frequently involving COVID should benefit. Now, as you pointed out, we didn't see that happen in ventilator-associated events. So, what perhaps did not occur with those patients that may have occurred with others So you aptly, saw that, if it was just infection control, then, why was there not a benefit with those patients? And I think that's still a good question. Anything else in the audience? And nothing else in the chat, but I think, this was a great discussion. I think a great introduction for simulation in infection control, and where this will take us, I think, is going to be exciting over the course of the next several years. And I think that's why CDC was really interested in us doing this, and why they've been so heavily involved in all of the aspects of what you are doing. So nice job.
Thank you.
Valenchia, thank you very much. It was very clear, to the point, and you just did it in 29 minutes. This is excellent. You're part of the team.
Thank you, Dr. Ramirez.
All right, very good. We will continue to have this available on the YouTube site, so you can use this again for our training. And we will see you then next Wednesday. Dr. Alan Junkins will be focusing on C. difficile, one of the things that we mentioned today, and we can see then, what is happening with C. difficile as we move through this particular wave of the pandemic. So we'll see everybody again next Wednesday.
Thank you.
Thank you.
Thank you.